Well, Nangkri Nangi, Nundiandu from Ngarrindjeri country today. Welcome to the Riverland Academy of Clinical Excellence Grand Rounds. And it's a time when the weather has warmed up and the river is starting to flood. What does that mean? It means for all of us who live in this beautiful country that we share with snakes and spiders that we become more obvious to them and they become more obvious to us. Today we have a world expert in the impact of venomous animals on humans, and it's our great pleasure to invite Professor Julian White to address us at our race Grand Round today. Welcome, Julian.
Thank you for inviting me. It'd be my pleasure. So hopefully you can now all see that title slide. I'm going to give you a brief update on clinical toxinology with a slight Riverland flavour.
Yes, we can see that perfectly, Julian.
Excellent. So principal toxin-induced diseases within Australia are snakebite, with maybe 1,000 or less cases per year, and only about 2 deaths per year, mostly from brown snakes. Spider bite, I'm sure many thousands of cases per year, but most of them are very minor, except for redback spider bites and the occasional funnel web bite, and no fatalities from either since antivenom's been available. Jellyfish stings, and of course there are a huge number of jellyfish stings, but it's only in northern waters at the moment that we have potentially lethal jellyfish, and deaths are now relatively rare. And lastly, paralysis ticks, which are definitely increasing in number at the moment in Eastern Australia following all the wet weather. They're not native to South Australia, but people could come back with ticks that they've acquired while on holiday in the East Coast or on their pets. They cause progressive ascending type paralysis. It used to be a more common cause of death than spider bite, but there haven't been any deaths from tick envenoming for a long time now, and we no longer have an antivenom available because it wasn't particularly effective. So moving on, I'm going to focus now mostly on snakebite. So all of Australia's medically important venomous snakes are members of the elapid family, so that's the cobra family. They have small to moderate sized fangs, and to give you some idea, a brown snake, an adult brown snake fangs are usually less than 3 millimeters long. Their venoms are systemically active rather than having their major effect locally. They're mostly diurnal, but nearly all of them will be active after dark, particularly on a warm night. And some have adapted well to urban environments, and that particularly applies to brown snakes. Depending on the sort of snake, depends on how much venom it has available. And for brown snakes with small fangs, they only have a small amount of very potent venom. So quite often a bite will not end up in significant venom being injected, and that's what we call a dry bite. The rate of dry bites varies. Brown snakes, it's probably maybe as high as 70 or 80%. But if you're in the part of the country where there are taipans, and there are 3 species in Australia of taipan, not native to the Riverland, I might add, their fangs are bigger, their venom glands are much bigger, and so the rate of dry bites is very small indeed. First aid is predicated on slowing the movement of venom to the systemic circulation, and that's why the pressure bandage immobilization technique, now around for many decades in Australia, is the preferred method. And the envenoming risks are essentially systemic, so quite different to snakebite in many other parts of the world. Most of that data I've already given you, but the important thing to understand is with snakebite deaths in Australia, most now are not only caused by brown snakes, but it's a particular problem of pre-hospital cardiac arrest. And indeed, the last fatal snakebite, confirmed fatal snakebite we had in South Australia was in 2006 in your area, in the Riverland. An adult, a male, bitten by a baby brown snake, who then had a cardiac arrest, didn't realise he'd been bitten, didn't do anything about the bite, and had a cardiac arrest less than an hour after being bitten. So, looking at Australia's dangerous snakes overall, there are 5 distinct immunotypes, and these correspond to the 5 monovalent antivenoms available. So we have the brown snake group, brown snake antivenom, the tiger snake group, which has a variety of species covered by tiger snake antivenom, the black and mulga snake group, mulgas are sometimes called king browns, which is a misleading name, covered by black snake antivenom, the taipan group with taipan antivenom, and the death adders with death adder antivenom. And of course, there is a 6th antivenom, polyvalent, which covers all of these. There are a number of other venomous snakes in Australia, varying from very small and really harmless to humans to moderate size and can cause mild envenoming. If you want more information, there is the toxinology.com website. There are the guidelines, which I hope you're all aware of, downloadable as a PDF from the SA Health website. These are the official SA Health snakebite and spiderbite guidelines. There is a book produced by the antivenom producers CSL, which is available free as a PDF from the toxinology.com website. And this relatively recent book on Australia's dangerous snakes. It's not a medical book, but it's got a lot of useful medical information within it. So what about the Riverland? Well, brown snakes are probably top of the list for you, but along the river corridor, you certainly will find tiger snakes. Now, I've certainly seen them there a number of times. Only north of the Murray, so once you're up out of the valley and into that pastoral country to the north, you'll find some mulga snakes. I've certainly seen them there. And it used to be a small pocket of death adders around the Morgan area, again, just north of the river. We're not sure whether they're still there or whether they've become extinct from that area. Some key points on snakebite management. Remember that snakebite can be lethal, and you've got to manage all cases as if it's potentially lethal envenoming. So high priority. You need to have lab evaluation, and you're fortunate in the Riverland to have the Berry lab not too far from you. INR stat machines are not reliable in snakebite coagulopathy. We think that D-dimer stat machines may be useful, but that's yet to be proven. All query snake bites need to be observed for at least 12 hours from the time of the bite. That usually means overnight. And antivenom doses these days are lower than previously recommended, but a policy which is being pushed from the eastern states and in a number of publications now saying only use 1 vial of antivenom, I strongly disagree with. I think that's not an appropriate dose for some types of snake bite. We strongly recommend that you seek expert advice, and that will be through the Clinical Toxinology Service at the Women's and Children's Hospital. The new system, which was recently introduced, which I'll mention further later, means that I'm not the only one taking calls for that. So some key points about antivenom, and antivenom is the key treatment for significant envenoming. There isn't universal agreement amongst experts about when to use antivenom and what dose is appropriate, and that is a change from 20 years ago and a most unfortunate one in my view. There are no nationally agreed guidelines, though one group's trying to push their own particular point of view. But remember, antivenom remains the mainstay of treatment for envenoming, and I would argue that includes for redback spider bite. A little bit of video now just to show you what a snake bite looks like. That's a form of brown snake. It's actually a dugite from WA. It was a captive dugite that I videoed in Adelaide. And just to reassure you, no snakes were harmed in the making of that video. And here's our volunteer again. And you probably saw the snake bite that person's back of that person's hand. But if we see it in slow motion, we'll see that in fact, the snake fails to connect fangs with skin and probably deliberately fails to do so. Yet the person and observers will probably say that person was bitten. So I hope that illustrates some of the ways that people can present as a query snake bite, yet no envenoming may develop. Venoms are very complicated, complex mixtures of toxins, and so it's impossible to go through that in full detail in such a short time period. But remember that snakes are continually evolving venoms, and so you can get atypical effects from bites by a particular type of snake because that particular specimen of brown snake or tiger snake or whatever has evolved a slightly different venom profile. So the principal toxins that we worry about are the neurotoxins that cause flaccid paralysis, targeting the neuromuscular junction, either pre or postsynaptically. And so that's a progressive descending paralysis first seen in the cranial nerves with ptosis. The second group of toxins are the myotoxins that cause systemic muscle destruction with secondary myoglobinuria. You get muscle pain, you can get secondary kidney failure, though I think that's quite unusual. But if that occurs, then you have the real risk of hyperkalemic cardiotoxicity, and that has killed people in Australia. The last group of toxins are the ones that we see most often in snakebite causing major effects, and they are those toxins attacking the coagulation system, particularly in things like brown snakes and tiger snakes. There are procoagulants that cause a rapid and often complete defibrillation. So each group of Australian dangerous snakes has a particular profile, and I'm not going to go through what those profiles are. Just be aware that they are important to understand in developing diagnostic algorithms, which are available in those SA Health snakebite and spiderbite guidelines. So now an overview of an approach to clinical management. All suspected indefinite snakebite should be managed as potentially lethal, as I said earlier. Ensure, obviously, ABC, that goes without saying, I guess, but sometimes it will be an issue because the patient may have had that pre-hospital cardiac arrest. Once you've dealt with that, then a targeted history and examination, at the same time ensuring IV access and giving an initial IV fluid load, and get those bloods off urgently. Make sure the lab knows that they are top priority, especially coagulation and particularly D-dimer. Don't remove any first aid, PBI, until you've worked out whether the patient is envenomed or not. And that might take you an hour or more, depending on how long it takes to get the lab results back. If on the basis of your examination and history and the lab results, the patient clearly has systemic envenoming, they nearly always will require antivenom, and you should start that before removing the bandage. Far more commonly, though, you'll be faced with the patient who has no good signs of envenoming and the labs are plumb normal. You can't leave the bandage on forever, so you then need to remove the bandage and wait an hour and then retest the bloods. But before you remove it, make sure you do have antivenom available in the hospital. Only patients with significant systemic envenoming require antivenom, and children get the same dose as adults. There's no such thing as pediatric dose for antivenom. Make sure you have good IV access. Make sure you've got adrenaline drawn up and ready, and resus equipment and staff ready, just in case you get an anaphylactic reaction to the antivenom. It's not common, but if it happens, you have to deal with it very quickly. So diagnosis is crucial in the management of snakebite. It's sometimes obvious, sometimes it's obscure. The person won't have even seen or felt a snakebite. And remember that a witness bite doesn't always mean that the patient has actually been effectively bitten, as we mentioned earlier. In terms of history, you want to know the circumstances of the bite, the geographic region, because that may give you a clue to the sort of snakes to consider. Multiple bites are bad news. You need to know about that. Description of the snake, photograph on a phone of a snake is really useful to me. If you've got something like that or a dead snake you can photograph, send that to me or whoever's on call for toxinology. It may really help us. Look for local symptoms and systemic symptoms and signs. Obviously, an examination. Get a past history. Medications, obviously someone on anticoagulants is going to interfere with your coag results, so you need to know that. terms of examination, look at the bite site, and if they've got first aid, just cut a window over the bite site just to examine it. There may only be scratch marks or tiny, almost invisible puncture marks, as you can see there, or it may be much more obvious bite marks, as in this tiger snake bite. There may be swelling developing over several hours, as you might see in a mulga snake bite. So look for multiple bites, oozing of blood suggesting coagulopathy, bruising, swelling, discoloration. Check draining lymph nodes, and then look for evidence of paralysis. The earlier signs, as I mentioned earlier, are ptosis, then ophthalmoplegia, dilated pupils, and then generalized weakness. And you can see that here with mild ptosis following a tiger snake bite, ptosis plus a partial ophthalmoplegia following a death adder bite. In a child where it's hard to get their cooperation, with flat faces suggesting developing paralysis. For myelitis, you're looking for muscle tenderness, weakness, pain or motion, and possibly myoglobinuria, so a change in the urine to a darker urine or red or even black or brown urine that may test positive for blood. For coagulopathy, look for oozing from the bite site, gums, and any IV sites. In terms of lab investigations, the full screening for snakebite requires the extended coags, complete blood picture, if possible, a blood film, renal function, CK, and electrolytes. And as I mentioned, point of care INR is not reliable. You shouldn't be using it, but point of care D-dimer may be appropriate, but we've yet to prove that. If the first aid is normal, remove the first aid, repeat after an hour, then at 6 and about 12 plus hours post-bite. And there is a chart available in those SA Health guidelines, which you can use if you wish, photocopy, etc., to help keep track of what's happening in terms of following that process. Specific treatment of snakebite with envenoming is antivenom. It's the treatment of choice for systemic envenoming. There are potentially severe side effects, as we mentioned, anaphylaxis, and also the delayed one of serum sickness. Antivenom may seem expensive, though by American standards in Australia, it's very cheap. But it's certainly cheaper than maintaining a patient on hemodialysis or on a ventilator for a prolonged period. Can't reverse all types of envenoming, and particularly presynaptic paralysis, once fully established, won't reverse with antivenom treatment. And clearly, therefore, it's best used as soon as there's an indication to give it, giving it IV, diluted, usually 1 in 10, though a high volume antivenom in a small patient, like a small child, you might have to accept a much lower dilution. Normal saline or Hartmann's are both equally good for the diluent fluid. Watch the patient carefully for adverse reactions from the moment you start the antivenom infusion, starting slowly and increasing the rate gradually, aiming to give the whole dose over about 15-20 minutes or so. So the indications for antivenom are any degree of paralysis, myelitis, coagulopathy. The neuroexcitatory envenoming is not for snakes, but for spiders. Any degree of renal damage, but I wouldn't give antivenom to a patient who had negative for all of the above and just had a headache, nausea, vomiting. But I'd be watching them very closely because those features can be an early sign of developing envenoming, but also an early sign of developing anxiety. And most patients bitten by a snake are anxious. So what sort of antivenom? Well, we have polyvalent. Why don't we use that for every patient? It's higher volume, it's more expensive, it has a higher rate of adverse reactions. So we prefer, if possible, to use a monovalent antivenom, but you need to know the type of snake. And that's where the use of a diagnostic algorithm, and if you've got it, swabbing the bite site for venom detection is a useful process. If you do both and they come up with the same answer, you have a high degree of confidence, you know what you're dealing with. If you do both and they come up with different answers, then you really need to be seeking advice, and you probably need to give a mixture of antivenoms. I'm not going to go through the diagnostic, excuse me for my throat at the moment, the diagnostic algorithms here. They're in the guidelines from SA Health. Now, I mentioned the dose issue, and you'll find plenty of literature around Australia saying you only ever give 1 vial of antivenom, and we strongly disagree with that. And the recommended dose for brown snake in SA is a starting dose of 2 vials, and for tiger snake at least 2 vials. For all of the others, 1 vial may be enough, except maybe for taipan bites in certain circumstances. The antivenom does have limitations. So as I mentioned, if you've got fully established paralysis from presynaptic neurotoxins, antivenom can't reverse that damage to the terminal axon, and therefore it's not going to reverse that type of paralysis. So there's no point in giving more and more antivenom to try and reverse it. The coagulopathy can certainly be reversed with antivenom, but particularly defibrillation type, where there's consumption of clotting factors, you have to wait for those factors to be replaced, which will take a number of hours. So you're not going to get an instant result. And for myolysis, there is conflicting information. I've certainly had experience suggesting that giving antivenom late can have some benefit, but it's unclear exactly what is happening. There is a decision tree for rural snake bites. So when you're in a setting such as the Riverland, when should you be considering transferring that patient to Adelaide? I'm not going to go through that. It's in the snake bite and spider bite guidelines. But the bottom line is, if you've got a patient with major envenoming, you'd want to be giving antivenom in the Riverland, and then we'd be thinking about moving that patient back to Adelaide. I do not think it's appropriate to be moving every query snakebite from a country hospital that has access to a lab back to Adelaide. I think it's possible for GPs to manage those cases in cooperation with us in Adelaide over the phone in their local area. That's better for the health system, and it's better for the patient and their family. What to do after giving antivenom? You need to observe the patient, obviously, making sure that things improve. You'll need to do repeat labs. And you need to tell the patient, since they've had antivenom, the symptoms of developing serum sickness in case that develops in 4 to 14 days post antivenom exposure. I mentioned earlier the IV fluid load. Watch where you put your needles, because if they've got a coagulopathy, every needle puncture is a bleeding point. So don't use the subclavian, jugular, or femoral veins, and avoid IM injections, such as for tetanus prophylaxis, until the coagulopathy is reversed. Most patients won't need analgesia or antibiotics. As a postscript, few doctors see many snake bites or spider bites, and therefore maintaining skills is not easy. And identifying snakes and spiders is a specialised area. So we're there to provide advice. Use that service. In SA, this has been around for more than 30 years. You ring the Children's Hospital and ask to speak to the duty clinical toxinologist. Now, as of August this year, the system has changed internally at the hospital. You still do the same thing. You phone the Children's Hospital. But these days, the first call will, in most cases, be taken by the duty toxicologist at the Royal Adelaide, who will then consult with me at the Children's Hospital. And the reason for this change is because there is now only one toxinologist at the Children's Hospital, that's myself, and I will need to retire sometime in the next few years. So I'm building up the expertise amongst my much younger toxicology colleagues at the Royal Adelaide. We're linking our two services together, and that will ensure that a service will be offered after my retirement. Now, from my point of view, I can briefly talk about spider bite, which will only take a few minutes. But Paul, do you want me to do that, or instead open up to questions at this time?
Why don't we see if there are any questions about the snakes first, Julian?
Okay, sounds good.
I'll open that to questions and looking for hands. One from me, just initially, you mentioned schistocytes needing to be examined for in the blood picture. What can you explain that?
Yes. So this is an area which is still incompletely understood with snakebite around the world, but particularly in Australia and especially with bites by brown snakes. A proportion, and we can't give an absolute percentage at the moment, of patients with significant envenoming by brown snakes who will essentially all have a defibrillation coagulopathy, either partial or complete, may develop a MAHA, microangiopathic hemolytic anemia. And that usually develops despite treatment and after the coagulopathy seems to be resolving. So you may not see evidence of it until 12, 24 hours or so post-bite. And it's a little bit like HUS. So you get intravascular hemolysis. That's why you're looking for schistocytes, spherocytes, etc. on the blood film. You'll see a decline in hemoglobin if it's a significant hemolysis. Those damaged red cells can clog the kidneys, so you can get a secondary kidney injury. And that varies from mild all the way through to complete anuric renal failure. But usually it's reversible renal failure with acute tubular necrosis. So after a period of hemodialysis support, you'll get return of kidney function. The other thing you see is thrombocytopenia, which can sometimes be very severe. So very low platelet counts. Again, not dissimilar from HUS in that regard. As I said, we don't understand yet exactly what is causing that. It's not clear if it's a direct venom effect or a secondary effect.
Thanks for that. My other question was, I've heard of outback people saying that the best thing you can do if you get bitten by a spider out bush is just to immediately lie down and don't move.
Spider or snake?
Snake.
In the days prior to retrievals and antivenom and intensive care and so on, that probably was about the only sensible thing that they could do. And in many cases, particularly if it was something like a brown snake, which is less likely to cause paralysis, if you're lying down, you're really quiet, the coagulopathy will self-reverse. It might take 24 hours or more to do so, but if you're lucky, it will reverse without causing kidney damage, etc., and you'll be able to recover. But it's not a guarantee, and I wouldn't recommend that in this day and age as the best approach to managing a snake bite. The biggest issue is if you're by yourself in a remote area, you've got no communication, what are you going to do? And there's no easy answer to that sort of question.
Thank you. Are there any other questions that people have on the snake bites? It's been such a thorough exposition of things, and certainly the resources are wonderful. Are there, so is that Louise, is that a question?
Yeah, I just write in the chat there, you mentioned anticoagulants. Does that actually have any impact on patient outcome if they're actually already anticoagulated and the snake bite can contribute to that additional bleeding and so forth as well?
That's a really good question, Louise, and I don't think there's a necessarily a tip-top answer available. I have to say, in those patients where they've been on anticoagulants like warfarin, etc., and then developed snakebite coagulopathy, I'm not sure that it's made it significantly worse. The biggest issue from my point of view is making it harder to interpret those initial coag results. And if someone's on warfarin, you'd expect their INR to be slightly increased. You'd hope that the range is not going to be above 4, whereas someone with a full-blown defibrillation coagulopathy after a brown snake, their INR will be greater than 12 because there's no fibrinogen left, etc. Again, the patient who's on warfarin, for instance, their D-dimer shouldn't be significantly elevated, whereas in defibrillation coagulopathy, it'll be off the scale. So there are ways of telling it, but if it's a patient who's only had a tiny amount of venom injected, then it's much more subtle. And probably D-dimer is your friend in that situation for both patients with anticoagulant therapy and those without. It's the first thing to show change. So you can get a significantly elevated D-dimer while the fibrinogen level, INR and APDT are still within the normal range.
Right, thank you.
Well, I think everyone would agree that we've had a really thorough run over this target. I certainly feel, Julian, more confident that we have a system that can support us when we're confronted by this as clinicians, and confident that in just about every occasion, with that appropriate first aid, once they get to hospital, we'll be able to have a good outcome. And that's certainly very encouraging. Thank you very much, not only for being with us today, but also for the decades of work that you've put in to our state and are now recognised globally for to make the world safer, so that we can enjoy the country with these beautiful creatures and keep ourselves safe at the same time. Thank you very much. And in the Ngarrindjeri language, we would say to finish, Nakan. Thank you, everyone.
Thank you.